End tidal CO2 has been a tool that's been around for nigh on 20, probably 25 years at this point, depending on when you kind of picked it up, but certainly since around the beginning of my little medical career itself. And yet, we see folks still, even at the advanced levels, that kind of act like they've never heard of this thing before. And that's really surprising to me because realistically, it's probably one of the things that's become most important in terms of assessing a patient, checking a patient's vital signs, or confirming that the dangerous thing that you just did to them actually worked out. Despite a number of different articles in both the sort of lay press or the semi-lay press about the bad things that happen when you don't use end tidal CO2, as well as enlightened commentaries and studies and RCTs demonstrating the use of end tidal CO2 and its benefits, a lot of folks still act like we don't really know about it. So I'd like to give you, if you haven't heard of it before, maybe a little bit of a primer on it. And we'll kind of talk about the different things that you can do as well as learn how to use it well, because it's not just checking tube placement, although that's a big part of it. End tidal CO2 works based on the fact that you generate a continuous flow of carbon dioxide in your body just through your regular metabolism. Because you live and you have ATP, you generate carbon dioxide. And typically it sort of swirls around your body in your blood until it gets to your lungs, and then it is off-gassed essentially just by partial pressure, meaning there's a higher concentration in your blood than there is in the alveolus itself. It's drawn out just based on the simple old process of diffusion and gases going to where there's less of themselves. And then it's expelled out of your body through that. And it goes out through your little alveoli and into your small airways, and then into your large airways, and then to your bronchus, and then your bronchi and the trachea, and then out and into the atmosphere itself, where there's really not a high concentration of CO2. So if you look at, what concentration of CO2 is, or what the partial pressure of CO2 is kind of floating around, as I'm talking right now, it's almost zero. It's not entirely zero, it's like a percent, a couple of percent, something like that, maybe. So how do I actually generate an end tidal CO2 waveform? Well, it works something like this. While you might think like, okay, here's a zero down here, so this must be the part where I'm breathing out. No, it's based on your respiratory cycle, but where you actually breathe out happens here, and where you are breathing in happens here. So this rest period, this first line that's near zero, that represents, again, ambient CO2. Whatever's floating around out there in the atmosphere, because at that point I have breathed in. So this line is what happens when you take a breath in and you draw fresh air past that sensor. Because there's essentially zero CO2 in the air, it goes to near zero. When I breathe out, I blow CO2 from my body back past that sensor, and I generate this sudden uptick. So this is all exhalation. The wave itself is exhalation, and it is movement of CO2 from, again, somewhere deep in my airway to past the sensor one way or the other. Now, I've exhaled and generated that plateau. This is when we talk about what's your end tidal CO2, this is what you're actually measuring. Now, when I take another breath back in, I again draw fresh air past the sensor itself. And so that number goes again back down to zero. And that happens, as soon as I essentially clear out the sensor itself. And so when I draw air past that, it contains zero CO2, and we go back to zero. And it should go back to zero each time, unless there, for some reason, is some gas that is trapped in that sensor or trapped in your airway or something like that, which there's a little bit of, but again, it's close enough to zero, generally speaking, that you don't see it. What this really means is that end tidal CO2 is not so much a measure that like, oh yes, airway's intact or something like that. What end tidal CO2 means is that when you get a waveform, it's a sign that carbon dioxide made it from your blood to the sensor, because that's the way that it goes. And if something along that way stops it, and there are many things that could, or changes it, then you don't get the same number and you may not get the same pattern. And so we'll talk about some of that stuff. One of the most visible ways that you'll see people use End Tidal CO2, and a really good way to use it, is to check confirmation of an advanced airway device. Although it doesn't have to be an advanced airway, it could just be any airway. And again, why? Because End Tidal CO2, a good measurement, means that air, or gas rather, carbon dioxide, has somehow made it from your blood up through your airways and out to the sensor itself, and theoretically out of the body. So that there is, theoretically, a pathway between your blood and the atmosphere, which is what you're supposed to have. And so use as an airway confirmation device is super. Now, you may say, well, isn't this End Tidal CO2? Yes, it sort of is, or rather it's exhaled CO2, this little color changey thingy. Yeah, he sort of gives you a number, kind of, but mostly just, if it turns gold, okay, cool. And that's great, except this thing can get fooled pretty frequently. It is not good enough to confirm probably one of the most important things that we have to confirm, which is that our advanced airway, the thing that we've done that will allow the person to continue to survive, we have to make sure that is actually functional. So this guy's just not going to cut anymore, not standard of care, 100%. Why is it so important? Aren't there other ways of confirming tubes or your advanced airway placement other than just using End Tidal CO2? Well, okay, you might say I documented equal breath sounds. Well, you know what? Equal breath sounds are documented in 95% of misplaced tubes. How about mist in the tube? Fog in the tube was noted in 85% of misplaced tubes. Well, how about I saw the tube go through the cords? In 50% of misplaced tubes, somebody says, I saw it go through the cords. And you may say, well, how in the heck does that happen? Well, here's kind of why. You look at these cords here and think okay, great view, I got this. And you tell somebody, yes, I see that tube going through those cords. And you may even look at it afterwards and say, yes, 100%, that's got to be there. And you put End Tidal on it and you get nothing back. Or you get maybe a little spike back and then it goes away. Why? Well, because our eyes get fooled sometimes. Because if you pull up hard enough, you can make the esophagus hole look a lot like the hole in between your vocal cords. And so simply saying, I saw it go through the cords is not good enough. How about these esophageal bulb detector things? Man, if anybody's using those, people say, oh yeah, they worked great. Well, no, they didn't. And even if you did get it in the right spot, cool. How do you know it's still in the right spot? And that's the thing that really makes a big difference for it, is that you can continuously monitor that you are still getting gas come up out of the airway and through that tube itself. And if that stops, then you know something has gone wrong. How many times have you moved a patient and you thought, nothing's changed, and the tubes, has slid out or moved a little bit, or maybe it was just kind of hanging in there right in the first place? Because this guy will give you, yes, a good End Tidal CO2 signal. And you'll say, well, that tube's not in the right spot. Tube is in the right spot-ish in that it's allowing gas to pass, but if you move a little bit and it falls out, well, it'd be good to know about that, because you saw again that tube go through the cords. Did it stay in the cords? And that's one of the critical things that we are proving with End Tidal CO2 measurement. Now, I mentioned in the beginning and kind of blew past an article that said, do it for Drew. And that's the story of this adolescent here. Tragic story. He was skateboarding, had a minor head injury, was taken to a hospital, and they wanted to transfer him to a pediatric hospital that could be evaluated by neuro or whatever. Awake, talking, all that kind of stuff. For some reason, somebody became concerned about his airway before transport and said, we need to intubate him. So they intubated him, went okay. He was sedated and then woke up somewhere in transport, maybe a half hour out from the hospital. The ambulance crew stopped, reparalyzed him, RSI'd him again, and what they thought was replace the tube. Only tube was never in the right spot. Now you have a kid paralyzed with a long-acting paralytic, with no airway, nobody breathing for him, just started to crash and arrest. I believe I've got that story correct. This is something that should never happen. Definitely a never event, of course. An unrecognized misplaced tube is a never event, let alone a needless pediatric death from it. And again, I am sympathetic because medicine and emergency medicine and airway management is a hard job, but we have the tools to tell that this wasn't either the tube wasn't in the right spot or that it came out at some point. And we would have known, if End Tidal CO2 had been used in a proper way, that this kid was not exchanging gas. And it could have been corrected shortly, and it would have been a blip on the radar and a slap on the wrist rather than a poor kid dying. Around a quarter of tubes that were misplaced happened and were not recognized without End Tidal CO2. If you used end tidal CO2, that number dropped to 0. So use of end tidal CO2 is the gold standard for confirming that the airway is not only in the right spot, but that it stays in the right spot. If you have a tube in the right spot, it will make an end tidal CO2 waveform and give you a reading almost all the time. And this is proof. This is what happens when you do it to a cadaver that had been stored at freezing temperature for 32 hours and then taken out, intubated, and started ventilating. And when you start ventilating this cadaver, someone that is clearly dead, you do get an end tidal CO2 waveform. Now we'll talk about what an end tidal CO2 waveform means later. But after you start doing some CPR on it, you do generate end tidal CO2. Here it is for 30 minutes or so. You are still generating at least a number. It's not a number that's particularly compatible with life, but it at least tells you that your tube is in the right spot. So there is nobody that end tidal CO2 essentially won't at least kind of work on to tell you tube is in the right spot. And if you don't have a waveform confirming at all times that your tube is in the right spot, then the tube is in the wrong spot. And I strongly adhere to that. And that's a hard way to look at it, but that is the only way that we can afford to look at it. If you don't have a waveform, then I am left to assume that tube was in the wrong spot, and we cannot have that. Typically speaking, if we believe that there's a machine fault and that's why we're not getting an end tidal CO2 waveform, we're about to hurt somebody. We cannot afford to say that there is some kind of malfunction and thus assume that the end tidal CO2 is not reading because it's the machine's fault. And well, yeah, those things break all the time. That's not good enough, because the downside is that we will absolutely kill somebody when we assume that. Now, you may be able to prove it, but you cannot just assume that the end tidal is not coming up because the machine is not functioning. I had a crew bring in a patient one time that was in cardiac arrest, and I looked and there was no end tidal CO2 reading, and there was nothing at the top of the tube, and well, nothing seemed to have been done about it. And I asked, well, how come you guys don't have end tidal on him? The paramedic said, well, because it keeps filling up with vomit, and so it wasn't working. Well, it keeps filling up with vomit because the tube was in the esophagus. But we cannot afford to think that. You have to prove that everything else is exactly right, and there's no way this tube could be misplaced before you can say, well, the machine's just broken, so I'm not going to worry about the end tidal. It's never the machine. Or rather, you can never afford to think it's the machine, because your patient is relying on you to use that. And if our gold standard is not working, if you suddenly fall off here, you can't just say, well, that's probably, the device just has a little bit of spittle in it or something like that. What does it mean if the airway or if the waveform goes away? Well, that means the airway went away. Something happened. The patient coughed it up, gagged it up, it got pulled out, moved around, occluded, something happened. If there was a waveform and now there's not, now there's no airway or gas exchange, and you got to fix that right away. You cannot say that things just broke. So one more time, how does the machine generate an end tidal CO2 waveform? Well, CO2 is carried around as sort of a waste product, a byproduct through your body, dissolved in your blood, and then dissolves across this membrane or flows across this membrane because there's a low concentration of CO2 in your alveolus, and then it gets blown out with the rest of the gases that leave your lungs. When it goes past the sensor at the top, it creates the waveform itself. Now, one thing that's important, we've talked about how, you have to have an airway, which is sort of this part, in order to allow gas to get to that sensor. We hadn't mentioned so far, though, that you do also have to have blood carrying that carbon dioxide past the alveolus to be able to get out there. And then you have to have a functioning alveolar membrane and a functioning alveolus in order to move that CO2 out as well. So there is a little bit more to it. You have to complete that whole pathway in order to use end tidal CO2. So yes, good for airway, but if you don't get a waveform, there might be something else going on other than your airway being bad. What might be those things? Well, it's essentially stuff that prevents blood flow from getting to your lungs. So this giant blood clot blocking off your lungs might be responsible for it, because you're just not getting flow past the alveoli in order to off-gas that CO2. That could be what's going on with it. You may not look at a whole lot of echoes, but this is supposed to be your heart filling here, and what you see here is fluid filling the pericardium, squishing the heart, which is not able to fill, and so you're not getting blood flow past the lungs. This is a case of tamponade. You might get a tremendously low end tidal CO2 with this. Now, you will still get a number, a waveform, if the tube's in the right spot, but say the tube is in the right spot and you're getting a low number, this might be kind of why. Or the tube could then, again, be in the wrong spot. I saw it go through the cords. These cords, that's the esophagus. Actual vocal cords are up here. You, again, have to prove that the tube is in the right spot. You can't afford to think it's something else, but nothing that doesn't give you a good end tidal CO2 is a good thing either. So you got to be aware of that. And again, one more time with feeling, if you intubate a cadaver and then start ventilating it, you will get, you can see right down here, you will get a little tiny waveform. The number may not be a lot, but you'll get a waveform. No end tidal CO2 waveform or an inappropriate end tidal CO2 waveform means one of two things. One, something very uncommon has happened, like a hugely massive PE, and we're talking not just like a massive PE, but a huge one, or the pre-hospital tube is in the wrong spot, which is not honestly uncommon, and somewhere between 1 out of 5 and 1 out of 2 times happens. So what do you think the most likely thing is? Well, probably that tube's in the wrong spot, but not necessarily so. So if you tell me, well, I'm really sure the tube was in the right spot, is there some criteria that we can use to say, well, maybe he's got one of these other things happening? So there are some ways to evaluate the quality of your end tidal CO2 tracing, and to say that, yeah, I believe the tracing or I don't believe the tracing. And I think that either the tracing is good and that the tube is in the wrong spot, or that I think that the tracing is bad and the tube is in the right spot and it's something else that's happening. So this is the PUMA criteria. This is stuff that the Brits have come up with. Just to run through it super fast, it relies on 4 criteria. 1, that the number goes up during exhalation, makes that waveform, and then goes down during inspiration, and that it doesn't just happen randomly as you see in this first red tracing. Number 2, that it has to either stay the same in terms of the end tidal number or go up over the course of 7 breaths. If it goes down over the course of 7 breaths, then you are concerned that maybe you're just ventilating a bag like the stomach. And when that number ventilates all the CO2 out of it, then you will find out that the patient is actually dying because you're not breathing for him. Number 3, the number itself has to be at least 7.5 millimeters mercury, has to go up by at least 7.5 for the breath to actually count, and then it has to be clinically appropriate. If the number is 120 for whatever reason, well, that's probably not clinically appropriate. If the number is 3, that's also probably not clinically appropriate. If the number is somewhere between, say, 15 and 35, 45, 50, then that's probably clinically appropriate. And again, that means you have to know something about your physiology, so you can't just look at this and kind of take your brain away from it. You have to be able to say, yeah, that makes sense in this clinical case. If you satisfy those criteria, level goes up and down, looks like a normal waveform, stays the same over a series of breaths, makes sense for the patient, and is at least 7.5 millimeters of mercury in amplitude, then that's probably a good criteria, and you can say, yeah, tube's in the right spot, something else is going on, or not. If you don't meet that criteria, then you say, yeah, maybe it's not the airway itself, maybe something else is happening. Let's say, though, that the end tidal CO2 is not convincing. Before you go yanking that tube, as I kind of told you before, like you can't afford to say that it's just the measurement device or it's something else that's causing it. You have to ask yourself, is the patient okay? Let's say we have suddenly an unconvincing end tidal CO2. The first question you ask is the patient okay? Do we need to move right now, or are they hypotensive and bradycardic or in arrest or severely hypoxic? If the patient's not okay, then you pull the tube or the airway or whatever it is and you begin to ventilate with a BVM and you reconnoiter. If the patient is okay, then number 1, don't panic, because there is a good chance, at least a non-zero chance, that, yeah, something else may have happened if the patient is still okay. So avoid losing your mind and yanking every tube that comes out. Take a laryngoscope, look in and see the tube. If you have video, even better, take a picture of it actually sitting there. We can definitely identify and say, here's the hole that's the esophagus, here's the arytenoids, here's the glottis itself, here's the cords, here's the tube, here's the numbers on the tube, and I know it's in the right spot. Okay, if you do that, and you clearly see that, 100%, then okay, that's pretty good tube. Maybe try changing the end tidal CO2 collector, the thing that sits on the top of the tube, because yes, those fail as well. Push comes to shove, you can remove and reinsert the airway if you're not convinced by it, and then pull it if you're in doubt still at the end of the day, and ventilate with the BVM. That's all, again, assuming that the patient stays okay. As long as they're okay, you have some time to sort of figure this out. What you can't do is just ignore it. That's where you really get into problems. Yes, if you don't have end tidal CO2 on the patient, you assume that the tube is in the wrong spot, but you have a minute to fix that. You just can't look past it. You can't ignore it. Now, one of the other handy things about end tidal CO2 monitoring is that you can use it not just to say, yes, tube there, tube not there, airway not there. You can use the shape of it, the characteristics of it, to do a little bit of clinical evaluation. So this is a normal looking waveform, and we again have talked about what makes a normal waveform. It's got sharp little edges at the top. It goes down when they breathe in. It goes up when they breathe out, or when you bag. It goes along with it, and it's got, again, these sharp little corners and straight lines that go up. That's a normal looking end tidal CO2 waveform. Let's look at some other ones. Say that instead of, again, you have some pictures of normal here. Say you start getting something more like this, and you notice that this back corner, kind of right here, is starting to get kind of, well, smushed out. You still have this front corner. So again, look at the parts of it. What's happening here? We are breathing in. End tidal CO2 goes across, it goes pretty quickly down to zero, exactly as you expect. But then as you start to breathe out, that number takes a minute to get to sort of the top of the peak. It messes with your exhalation, whatever is going on here. What would cause you to have a slower expiratory volume and not get CO2 out to the detector quite as fast? Well, obstructive lung disease. The thing that makes you exhale slower, asthma, COPD, the thing that makes you, instead of going and breathing out fast, the thing that makes you go through little constricted small airways. This is the classic shark fin thing, and this is a sign of obstructive lung disease, COPD, asthma, those guys. How about this particular one? Again, this is normal looking here, and then let's say we're going to switch over here in just a second. What we saw was sort of a gradual little curve up into it. The more obstructive your lungs get, the less time you have to actually make this plateau. So we're blowing out more and more CO2 the entire time. All this is showing is that you are getting worsening obstructive disease or worsening obstructive pattern. It's taking longer and longer. Instead of blowing out right away, you blow slowly. So the steeper that line gets, the less curve or the less angled it gets at the top, the less time you have for a plateau, the worse your obstructive lung disease or the worse your obstructive pattern is. Here's some other important ones here. So we're ventilating this patient here. We're bagging, and then it looks like that. What happened here? Could be that you lost your tube. You could have popped the BVM off the top of it and you're no longer exchanging gas, and these are just a couple of little breaths the patient's taken. If the patient is spontaneously breathing, it means that they're no longer breathing effectively, or they have a long apnea period here. How about this particular one? You may notice this one. We said before that for a good tracing, you really have to go all the way back down to the bottom. And different graphs will put it in different ways. But this is an example where the trace itself doesn't actually go back down to the bottom. It doesn't go to zero. This is called rebreathing, which means that for some reason in the tube itself, fresh air is not effectively being drawn in. You're not clearing out whatever the ventilator circuit or something like that. Now again, some tubes, you got to watch the scale on it. Some tubes or some tracings may kind of just look this way and float in the air, but they should go all the way back down to, again, pretty near zero each time. And how about this little thing here? I've seen this happen a couple of times. Somebody comes in, patient is in arrest, and the EMS crew says, yep, have end tidal on, getting an end tidal of whatever I said here, 15. So pretty low. And then I look at that tracing and I think, well, that again, based on that criteria that we've looked at before, that doesn't really look like, a breath the way we kind of think of it like this guy does. What's going on here? If I were to put time on this, these are going at about 110, 120 breaths a minute for these little shallow things. What's happening here? This was when the tube is stuck in the pharynx and air is being blown past it with each chest compression. You notice we're not getting an actual waveform. It's not doing the stuff that we think it should. It's doing this little other thing that doesn't make any clinical sense, and it doesn't correspond with how we're breathing for the person. And so, yes, this is a CPR waveform. This is a tube that's in the hypopharynx, and little bits of CO2 are getting poof, 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 pushed past it with each one. Yes, this is an end tidal CO2 tracing, but you have to know something about it. It's not enough to just say on number and everything's okay. What happens here? We have a good looking waveform, and now we got almost nothing. The number itself goes down. We don't see the sharp patterns that we were seeing before. If it's an intubated patient, you'd say this is loss of the tube. If it's a spontaneously breathing patient, then we'd say, that patient no longer breathing. And maybe we don't know that they're not trying to breathe, but for whatever reason, gas is not being picked up by that end tidal CO2 sensor, and we can't tell that it's being exchanged from the blood out through the airways. SpO2, the thing we say like, oh yeah, they're breathing fine. SpO2 doesn't really tell you that. It lags by a minute or two, often behind true hypoxia, the time when you actually stop exchanging gas. So say you give somebody a bunch of ketamine and you're using end tidal CO2 to monitor whether or not they are breathing, you're going to figure that out a lot faster than if you were just watching their sat, and a lot more reliably. Let me prove to you a little bit of that. So let's watch this poor devil here. You'll notice that he is initially breathing and there takes a breath and holds it. Now we're at sea level, room air. He's a reasonably healthy, possibly slightly out of shape guy, but you see his pulse ox at the bottom and his heart rate. Heart rate in the 60s, pulse ox 99% at baseline. He's been holding his breath so far, and definitely apneic, 100%, but you notice that the pulse ox itself has not changed, has not flinched, has had plenty of time to do so if it was actually detecting apnea. Similarly, heart rate staying about the same. Blood pressure would be about the same. Now, comfort level, not very comfortable, but you'll see in just a second, oh man, we dropped a whole point. We've been apneic for now probably 30 seconds. As CO2 builds up, the desire to breathe goes up with it, and the comfort certainly goes down. But you'll notice we still have not changed our SAT. 98%, still a heart rate in the 60s. You would continue to say, even if this patient had been apneic this whole time, seems fine, SAT's fine. And yes, I'm still awake and conscious, but there's a minute where I dropped my pulse oximetry by about a point, but was completely apneic that whole time. End tidal CO2 is the best way to detect apnea. End tidal CO2 can also do some stuff for us that we might not be able to see otherwise. And that's based on kind of the effect of our treatment. So we often say that, a normal end tidal CO2 is between 35 and 45 millimeters of mercury. And that's kind of based on the idea that a normal P CO2, the dissolved concentration of CO2 in your blood, is between 35 and 45. And again, normal varies from person to person, but typically this is what the population does. Normal-ish for somebody with COPD may be significantly higher. Somebody with bad sleep apnea or Pickwickian or stuff like that, maybe a bit on the higher side, but this is a quote-unquote normal number. Why might we want to change that number around? Well, one thing would probably be in the setting of head injury. We've all seen this before. This is not every head injury. The indication really is if the person has such increased intracranial pressure that they are about to herniate, meaning that they are both unconscious, because you wouldn't be about to herniate and be conscious and require this. They have to be unconscious, and they either have to have blown a pupil or they have to be posturing. At least one pupil, and they have to posture. Again, and that could be decorticator to cerebrate, either flexing or extending. If they are posturing or have a blown pupil and are unconscious, then that is somebody that should probably get mild hyperventilation from us if we are controlling their ventilatory rate. And why do you do that? Because if you decrease, by blowing down CO2, by making that number less, what you do is cause your brain to vasoconstrict, which we can talk about some other time about the mechanism of it. You vasoconstrict, and then the blood takes up less space in your brain than it would otherwise. It gives your brain a little bit more space to kind of sit in there and not get squished because of all this extra, leaking blood or edema fluid or stuff like that. And you can decrease intracranial pressure with that. Now, the problem with that, and why you don't want to do it a lot or real often or in anybody that you don't absolutely have to, is because it's bad for your brain. This is what happens to blood flow in your brain. Normally, you notice all the different colors and it looks happy. And this purple stuff is all essentially, ischemic area. It has not ischemia, but it has low oxygen levels. And this is after a minute of hyperventilation. This is why you feel weird when you hyperventilate and why sometimes you pass out, because your brain really is not getting the blood flow that it needs. So yes, if we have to, as our last resort, we might hyperventilate somebody a wee little bit to try to give them a little bit more time to get to a hospital or a neurosurgeon or something like that. But you don't want to do that for everybody because, well, decreased blood flow to the brain typically we call a stroke. So don't do that unless you absolutely have to. You might use end tidal CO2 to help determine how deep and how fast and what your compressions look like. So allegedly, you can use end tidal CO2 to monitor the quality of compressions. And if they are, and if your end tidal number is less than 10, then those are bad chest compressions, right? We've heard people say that. If they're good, they're greater than 20. And if you get ROSC, maybe jumped up to 35. Well, yes, that's sort of the case. But it also is a little bit strange because like sometimes you get an end tidal less than 10 because the person's dead. It's not always the compressor itself, but if you were getting end tidals of say 25 and then you switch chest compressors and now all of a sudden it's 8 and the person, looks like they're having a hard time, again, clinically it sure looks like probably this chest compression could be better. And yes, if you had a big old increase in end tidal CO2, maybe it's because the patient got ROSC and that's why. So maybe that'd be a good time to kind of stop or at least feel very closely, very carefully to make sure you didn't actually have a pulse at your next pulse check. By the way, can you use these things in all types of airways? Yes, you absolutely can. In fact, there's been a large amount of data that says, yes, you can use it on an iGel. Yes, you can use it on a King airway or a blind insertion airway device. Otherwise, you can use it on a mask, and the number is actually pretty close to what you get if you were to use it on one of the other devices or an endotracheal tube. So anything that you breathe through for the patient, especially if you're using good mask sealing, good technique, as you ought to be, will give you a reliable end tidal CO2 reading that's pretty close to what you would be getting otherwise. You have to know your equipment. And you have to know it pretty well because there's some little things that might make a big difference when you are using equipment. Even something as simple as a nasal cannula can really cause some problems if you don't use it correctly. So how many of us have ever tried this before? Putting an end tidal CO2 sensor on underneath a non-rebreather mask. And you'll see people say, well, that won't work. Well, yeah, actually it will. They are theoretically going to be pushing all that gas outside of the mask itself, and well, it wouldn't be in the end tidal CO2 sensor anymore. So you can use an end tidal CO2 sensor on a non-rebreather on a spontaneously breathing patient. And you can even actually turn up the oxygen flow through it and sometimes provide the person a little bit more inspired oxygen. Though at that point, we probably should be looking at BiPAP or CPAP, but you could do it. So yes, you can use it under a non-rebreather to at least monitor breathing. All right, you've probably heard of actinic oxygenation, and you should be using it if you're doing advanced airways in the field, especially if you are doing RSI. And the idea here is that you take a nasal cannula, you put it on the patient, and then you crank it up on the wall to as high as it goes. Not just to 10, not to 12, not to 15. You keep turning the knob until it goes and it makes that noise. That's what you want. You will get some passive oxygenation that happens during the patient's apnea period, which will give you more time to complete your airway attempt. Hopefully on the first time, even though it might take you a little bit more. The bigger question is, do you do it without complication? This helps protect the patient, gives you a little bit of wiggle room when you are doing your intubation attempt. The thing is, you can't just use any old nasal cannula on it. You have to know what it is that you're doing. So, for instance, one of the end tidal CO2 measurement devices, the nasal cannula only delivers oxygen through one nostril, which is important to know as well, because if that one nostril is clogged, then the person may not be really getting any oxygen themselves. But it samples through one side and delivers through another. Another one of these devices may be able to deliver oxygen through both ports, but not at a very wide bore, and then they sample through the same thing. Typically speaking, the capno cannulas that we all see, you know, the ones with the little pillow thingy that fits underneath their mouth or over top of their mouth, you may think that you are actually delivering oxygen through those little prongs, when in fact you are not. You are collecting CO2 through the little prongs that fit in their nose and through the thing that fits in front of their mouth. But you are actually only delivering oxygen. If you look at the device itself, you'll see on this barrel that sits outside their nose, that is where you are actually delivering oxygen. The idea is it creates a pillow of oxygen on their face. But if you take this and turn this up to, flush rate, whatever will come out of the tank as fast as you can, then yeah, you're just blowing oxygen on their face. You will not actually get effective apneic oxygenation. You won't be able to augment what you might be doing otherwise. To go back to another use here, can you put it on underneath a nebulizer mask so that you can monitor the change in waveform as they get medicine? Yes, you can, because again, you're really not worth mentioning one more time, you do not actually oxygenate through these little holes. This thing collects CO2. These little guys collect CO2. The oxygen actually comes out here and sits outside the patient face, and that's based on both the pediatric and the adult size. So you can certainly use them. They're great tools, and they're excellent at detecting apnea, but you have to watch out because you may not be able to oxygenate as effectively, and you won't be able to do apneic oxygenation through these guys. Now, we can use end tidal CO2 to say a lot of things about a patient that we are monitoring. Not just the absolute number, but we've talked about the waveform, we've talked about the clinical context of it. Let's say here that we have a known diabetic male at a nursing home that's not acting right today. We put a monitor on him and we get something like this. You see that he's tachycardic, a bit soft on the blood pressure. We get an end tidal CO2 of 11. If we pair that with a simple finger stick that's greater than 600, what's the diagnosis? Well, he's probably breathing fast at a rate of 31 to blow off CO2 because he is in diabetic ketoacidosis. And that makes sense. We can basically make this diagnosis in the field. Similar sort of patient here. You notice that the patient is hypotensive, again, a little soft, tachycardic, low end tidal CO2, high respiratory rate, SAT's okay. We'll say the finger stick's okay on this one, but she's coughing up a bunch of yellow junk. What do we think about it? Well, she's got a fever. This is probably somebody who's septic and maybe in shock. All the parameters line up for it. Sepsis would be a reasonable thing to suspect based on this, and you might not be able to tell that without your end tidal CO2. Actually, there's probably a good chance that you already figured that out, but, well, let's just say that it is something else you could do. How about this person? This is an asthmatic. You find out that initially they have an end tidal CO2 of 75, and they have this sort of pattern on their end tidal CO2. This is a person that's fairly sick off. You give nebs to them, and that number now goes down to 30. You may say, well, okay, great. We have improved things. Their respiratory rate has come down as well. The person's looking more comfortable. Clinically, we can objectively measure that the person's gotten better, unless it really falls off. What could be going on here? Well, now the patient's not exchanging gas anymore. They've gone from really blocking it off, or from really having an obstructive pattern, to barely getting any gas out at any time. And now the breathing is getting slower. This is a patient that's tiring out and in imminent respiratory failure. We can again use end tidal CO2 to help figure that out. All right, we can use it on this patient as well. Let's say that he's intubated. He's got the wounds that we see here. His motorcycle crash, his GCS is 5. We snake a tube down his trachea, and we put end tidal CO2 on the end of it, and we get something that looks like this, pretty similar to the other guys here. Now, when I look at that, you may remember me saying, well, a normal end tidal CO2 that we typically aim for is somewhere between 35 and 45. Or on the low end, even mild hyperventilation should give you 30 to 35, thereabouts. And that's kind of the goal. And here his respiratory rate is not only higher than 20, but his end tidal CO2 is way low. And so you look at that and you remember Walt saying, oh yeah, that means that they're not getting blood flow to their head, so I'm doing a bad thing. So then, because you have control of this guy's respiratory rate at this point, you slow him way down. And you start bagging them at about 10 times a minute. That's an extremely dangerous thing to do because you don't necessarily have the full picture when you do something like that. The problem all becomes in our acid-base balance. So we are constantly out there making acid. Our cells are constantly doing it. It's just what happens. But we're generally speaking pretty good at getting rid of it. We don't hold on to too much of it because we function at a pretty standard pH. And so our body puts it in our blood in the form of, well, some chemical reactions, and we blow it off through our lungs. We have to have a way to get rid of it. So the way that this is all regulated, the acids and the bases and all that kind of stuff, is a complex interaction between your blood and your lungs and your kidney. And it follows this equation, something like this. The easy thing to kind of remember without having to think about all of it is that you have an amount of carbon dioxide in your blood that has to essentially come across this equation and balance out with the amount of acid and the amount of bicarb, or the two things that sort of go into regulating your pH itself. The CO2 is determined by your lungs, the bicarb level is determined by your kidneys, and acid is just the H+, the hydrogen ion, that just kind of floats around out there. It happens fast in your lungs because that way you can control, you have a means to be able to regulate your pH when something really significant happens, like you have to run from an alligator, and it goes slower in your kidney because your lungs can't do it for very long, and so it takes your kidney to kind of regulate things over the long term. Let's look at it from a real simplistic sort of way, and let's just say that both sides of this equation sitting in your bloodstream have to balance out, which is essentially your CO2 and your bicarb, which isn't really going to change that much, but we'll call it the level of hydrogen ion or acid in your blood. So acid here, CO2 here, both of these have to level out. So if CO2 drops, then acid will drop. If CO2 goes up, then the H+ ion goes up, and you'll become more acidotic. So again, CO2 is regulated essentially by your lungs, bicarb by your kidney. We're mostly going to look at the lung side here and look at these parts of the equation. When you breathe faster, you get more carbon dioxide, typically, not all the time, but you tend to get more carbon dioxide leaving the body itself. As you lower your carbon dioxide, it pulls that hydrogen, that again, everything has to even out, and so you pull that hydrogen ion over to this side. If you have less over here, that means you have to have less, and less acid means, well, less acid, more basic. As the hydrogen ion concentration goes down, you get less acidic, and your blood gets maintained at, the normal pH, which is good because we don't survive very well at lower pH. We actually survive not very well at higher pHs either. But let's go back to our patient with the motorcycle accident here, who seems to be, in all intents and purposes, in shock. He certainly has positive shock index. We notice that he has a low end tidal CO2, and we may say, I want to slow down his breathing to get that number back up to where Lubbers told me, 35, 45. Sounds like a good idea, right? Here's the problem, though. We know that, probably he has a PCO2 of around 11, but we don't exactly know why that is when we just look at this monitor. So his, or at least his end tidal, should be 11, and his PCO2 is probably something like that. However, we also don't know that it's because we're breathing too fast and he has a respiratory alkalosis because we're ventilating him at 30 times a minute, and he actually would be appropriate to drop down. We don't know that that's the case, or if it's the case that we are actually allowing him to compensate for shock. And because his bicarb is low, his hydrogen ion concentration is high, and that is being blown off by his body in an attempt to keep him from dying because of his terrible acidosis from his shock state. So we don't know, just because the end tidal is low, if it is because we are overventilating, at least right away, or because we are compensating for acidemia. And typically speaking, everybody that is acidotic ought to be breathing a bit faster than normal, and sometimes a lot faster and with a lot bigger tidal volume and with a lot bigger minute volume than somebody else. The problem is that if you slow this guy's respiratory rate down to 10, all of a sudden his pH goes from, say, 7.01 down to 6.5 because he's no longer able to blow off that CO2. Acid rises, and then he goes into VF and he dies. And that's very hard to get back once you actually get the person in to arrest themselves, almost unrecoverable. It's also worth noting that end tidal CO2 measurement only means that your blood has at least that much carbon dioxide in it. Because as I mentioned before, there's a big pathway between your blood and the actual outside world itself. End tidal CO2 can't be higher than the dissolved concentration of CO2 in your blood, but it certainly can be lower. And so you really don't know. If there was a big blood clot or something like that, and you're just not able to get blood past the lungs, past the alveoli themselves, then you may be building up CO2 in the body through here, but it just can't get past this giant blood clot. And so your PCO2 right here might theoretically be, 60, 70, but all you're reading on your end tidal, because that's what's going past your lungs, is, 10, 20, 30, maybe totally normal. Another case where that might actually happen is if you have bad obstructive lung disease and you trap air down in your lungs because it can't get out, and so you're just not able to get it up past the sensor. Now that has to be pretty severe at that point, but it certainly can happen. Or it could happen because the patient has essentially low or no blood flow to their lungs themselves, as we kind of mentioned before. So it's very difficult to say. The carbon dioxide level in their blood is at least as high as what they are breathing out, but it could be significantly higher, and that's where you have to come in as an excellent clinician and be able to make sense of these. So a low end tidal CO2 could be a whole bunch of different things, and breathing slower is sort of rarely the answer. Not never the answer, but rarely the answer when you notice it. And probably one of the most important things to know about use of end tidal CO2 is it's usually okay to fix a high end tidal CO2. But you have to be very careful trying to fix one that's low, because there's a good chance that you may end up hurting the person doing that. In summary, end tidal CO2 should be on every advanced airway, every tube, every time, gets waveform end tidal CO2 consistently throughout its entire use. If there's no waveform, the tube is bad until you've proven otherwise. Now you can prove it otherwise, but you have to prove it. You can't just assume that it is the detector or the device that has gone bad. End tidal CO2 is a vital sign, and hopefully we make the case that that should be used on many of our critically ill patients, if not almost all of them, in one way or another. You can't afford to assume it is the device. I've said that before, and I'll say it again. You can't afford to just think it is the device that has gone wrong. When you're measuring end tidal CO2 and you don't get a convincing waveform, you either have to prove it or do something else. And it is okay to fix a high end tidal CO2, generally speaking, but it may not be okay to fix a low end tidal CO2 if you don't know the whole picture of the patient's acid-base balance. And that can cause real problems real fast if you do it in the wrong way.